Yeah, of course. So, well, I mean, if I think back to when I first started working as a neurologist in stroke, it was around the time the trust was getting set up, it was around 2012. And it was around the time the centralised stroke service got set up in Greater Manchester, so the ambulances will take you to one of 3 open stroke centres, Salford being one of them. And so it was an exciting time because we were starting to deliver some of the treatments to ischemic stroke. So ischemic stroke causes 9 out of 10 strokes and hemorrhage about 1 in 10. So patients would arrive at the front door, we'd meet them, we'd rush them off to the scanner, and you don't know whether someone's got a hemorrhage or an ischemic stroke until you put them in the scanner. It's only then that you can tell. And what we used to, something I definitely observed at the time is that urgency had suddenly stopped. Most people saw it as a hemorrhage because there wasn't really much we could do at that time. Now, what happened in 2013 is there was a big trial published that showed if you lowered blood pressure really quickly after someone comes in with a hemorrhage, that it can reduce the risk of any further bleeding happening. And that further bleeding happens in about 1 in 3 people, and when it does happen, it happens really early, so it happens in the first few hours when they're in A&E or when they've just gone up to the ward. So around that time, when that trial had been published, we kind of thought, well, if we did all of these things really quickly and really well when patients came into A&E, would it make a big difference? So we focused on 3 things, which was if they're taking blood thinners, which about 20% of people are when they come in, things like warfarin or other blood thinners. So if we give the antidote for that really quickly to reduce the risk of further bleeding, and if we do this blood pressure thing and lower the blood pressure very quickly. And finally, some patients will have an operation to remove the hematoma in the brain, and that's about 5% of people. So we also put some referral pathways in, so we referred people really quickly. So those were the 3 things that we put in place. And we monitored what impact that had on survival after intracerebral hemorrhage when we first did it, which was in 2015-16. And what we found was that it reduced deaths by about 1/3 after intracerebral hemorrhage, and we were actually really surprised that it did, so we were obviously delighted. And so those kind of things have become part of what we do, and we've tried to expand that project up. So we've scaled it up across the north of England and have just finished that. We're trying to persuade NHS England to let us take it nationally and to do that nationally. But that's really only targeting one little bit of intracerebral hemorrhage, which is just that further bleeding. So the things Katie was talking about, trying to reduce the damage that the blood does to the brain around it, we don't have any specific treatment for. And there's a lot of work to be done with surgery and whether surgery will be beneficial. So this year, quite excitingly, we had our first positive trial of surgery for intracerebral hemorrhage, which showed that a special sort of keyhole technique did improve the outcome for selected patients. And there's a lot of trials going on at the moment, so we might see a bigger role for surgery in the future. So it's changed a huge amount, I think, in the last 10 years, but there's still lots to do.